So thanks again for the invitation to speak here. Today. It's a great honor. So I'm going to speak about the current treatments that we can offer for gastric and esophageal cancer. And as Vasiliki noted, I am a medical oncologist, so my bias will be about speaking about chemotherapy, and I will also mention surgery and radiotherapy. But I'm not an expert in those areas, so I'm very happy to take questions, but may not be able to discuss those in great detail. So to move on. Stop. So these are my disclosures. I'm going to talk, first of all, a little bit about treatments for early cancers, maybe not as early as our previous speaker has discussed, and then move on to treatments for more advanced cancer. So this has already been discussed, but I think it's worth revisiting, because while we speak about gastric and esophageal cancer a lot of the time in one breath, and we refer it to gastroesophageal cancer and esophageal gastric cancer, there are really more than two diseases which, as Professor has pointed out, have very different etiologies. We did used to treat them in a similar way, but now we're understanding more about the biology of these cancers. The treatments are starting to diverge. So here on the left, you can see where squamous cancers predominantly occur. So that's in the esophagus or the food pipe. And squamous cancers tend to occur in the top part of the esophagus. You can get them a little bit further down, but when we see a tumor in the top part of the esophagus, we assume that it's a squamous cancer, although of course that needs to be proved with a biopsy. Adenocarcinoma, a different type of cancer, is more common around the junction, what we call the GE junction, which is the gastroesophageal junction. And that spans from about 5 centimeters above the stomach to 5 centimeters in the stomach. So most of the tumors there are called junctional tumors, and those are the tumors that are associated with reflux. Then we move into the stomach, and in the stomach, it's adenocarcinoma as well. And there are different parts of the stomach, and each part of the stomach might need a different operation. So tumors at the top of the stomach, the cardia, tend to have similar operations to tumors of the GE junction and esophagus. But tumors of the antrum of the stomach, which is the bottom part of the stomach, and the pylorus, which is the part that goes into the next part of the bowel, the duodenum, have different surgeries. And each of these tumors, as has been touched on before, has different distributions around the world and different factors that cause them to occur, but also have different symptoms. So what we see predominantly in the UK, probably 70% of patients are now junctional and lower esophageal adenocarcinoma. They're associated with a high weight, with reflux. Barrett's is the precursor lesion. But unfortunately, most patients don't know that they have Barrett's. So once you have a diagnosis of Barrett's, generally, you're quite lucky because you'll be kept an eye on. Most patients don't know that they have Barrett's before they develop esophageal cancer. And the symptoms that are associated with high esophageal tumors will be predominantly difficulty swallowing. So the food gets stuck when it goes down, and weight loss maybe as a result of that. Then you've got your tumors at the bottom of the stomach, which are the distal gastric cancers. As we know, they're associated with H. pylori. These are rapidly declining in many parts of the world, as we've discussed. And many patients, so the symptoms for these are very subtle. And in fact, patients might have a feeling of fullness, they might lose a little bit of weight, they might have burping, but it's often not very obvious. And this is why these tumors can often be quite advanced when they're diagnosed, and sadly, many patients are not suitable for a curative treatment. And then we've got diffuse gastric cancer, which is a strange entity. It's not really like the other two cancers because the the cells in diffuse gastric cancer don't grow in a ball or a tumor. They spread out throughout the tissue. And the reasons for diffuse gastric cancer, beyond a small number of hereditary mutations, which I think we'll hear about later, are really not well described. The surgery that these patients might have is variable. So these are the tests that we will do for patients who are diagnosed with a stomach cancer or an esophageal tumor. As we've seen before, this is an esophageal tumor at endoscopy. So endoscopy is a camera test down into the stomach or esophagus. And here you can see the tumor is where it's a little bit lumpy, and you can see some ulceration there. That's the little bit of yellow. And you can sometimes see some bleeding. And in fact, some patients might be diagnosed with anemia and tiredness because of that. When a patient is diagnosed with, it has an endoscopy and they're diagnosed with a gastric or esophageal cancer, then we want to do staging. And staging is the most important aspect of the first part of the treatment, because then we know what's the appropriate treatment for the patient. So we will do a CT scan. And the CT scan, you can see a big gastric tumor here on the CT. Normally, the wall of the stomach on a CT is quite thin. So this arrow here is showing a thin wall of the stomach. But you can see the other arrow showing that the wall of the stomach here is very thick. And this would be abnormal. And we want to see if the tumor is coming through the wall of the stomach, going into any other organs. Some patients also undergo an endoscopy, which is a camera test or an endoscopy, but with an ultrasound attached to the camera. And that's pretty neat because it lets us see through the wall of the stomach or the wall of the bowel, and we can see how much the tumor is penetrating into the stomach, or whether there are lymph nodes close by that look like they're involved with tumor. And endoscopic ultrasound is very good for very early tumors and later stage tumors to understand invasion. The staging for esophageal and gastric cancer is here on the right. And you may hear when we discuss tumors, we'll describe a T stage and an N stage and an M stage. And that's a universally accepted way of staging tumors. And we know a patient's prognosis according to the TNM. And as you can see here, the T stage, so this is showing the wall of the stomach, and this is showing nearby lymph nodes. So as the tumor progresses through parts of the wall of the stomach, so very early, not invading much, then gradually going through the wall of the stomach, it increases in T stage. So from T1, which is very early, to T4, which is quite advanced. T1A and T1B, where they're just into the wall, might be suitable for a local surgery approach with using an endoscope called endoscopic mucosal or endoscopic mucosal dissection or resection. If we see lymph nodes, we'll classify the patient as having N1, N2, or N3 disease. And if we see metastasis, there's a little lever here in the corner because that's probably the most common site metastasis. We classify the patient as M1 or M0, which is no metastasis. So, because this is something that patients often see under letters from doctors and they don't understand, so we need to explain that to them. And the reason why we stage patients is because it gives us a good idea about how aggressive the tumor is and how likely the patient is to have a good survival after their surgery or their treatment. So you can see that for early stage cancer, so this is the proportion of patients who are alive at 10 years after a surgery. This is with no chemotherapy or radiotherapy. So these are a bit old data, but just to show the point. If you have a stage 1 tumor, there's a 70% chance of being alive in 10 years. But if you have a stage 4 tumor, a chance is sadly less than 20%. So that's why we use staging information to decide on treatment. Now, when we talk about esophageal cancer and treatment, it's really important to talk about early esophageal cancer first, to divide it into squamous esophageal cancer, shown here on the left, and adenocarcinoma. And that's because there is some overlap between the treatments, but there are also differences. These are the ESMO guidelines, so the European Society of Medical Oncology guidelines that were written by my good friend Lauren Lodick. So we have a new version coming out this year because there have been exciting changes in treatments. And for gastric cancer, there are also a number of different treatment options available that I'll discuss in more detail now. And these can be before or after surgery. In Europe, we tend to do before surgery. So I'm going to talk about squamous cancers first, squamous esophageal cancers. So early cancers which have not metastasized. So we're aiming for cure for these patients. There are two main choices. Patients with early squamous esophageal cancer can either have chemoradiotherapy, so chemotherapy and radiotherapy, followed by surgery, or they can have chemotherapy and radiotherapy alone with a higher dose of radiotherapy and no surgery. And that's called definitive chemoradiotherapy. And the reason why we can sometimes avoid surgery, even when we're trying to cure squamous cancers, is because they are very, very sensitive to radiotherapy. So it depends. And actually, there's not a consensus in Europe about which is the better choice for patients. Some centers will say, if we can avoid surgery, we should, because the surgery has a lot of side effects. And some centers say surgery is better because if you do chemoradiotherapy, there is a chance that the cancer can return. So that's a matter for debate, and it's being addressed in clinical trials at the moment. In fact, one very large trial called the NEEDS trial is addressing that. If you have adenocarcinoma of the esophagus, the treatment can share some similarities, but there's also a very key difference. So if you have an adenocarcinoma, you could have chemoradiotherapy and surgery, or you could just have chemotherapy and surgery, but you must have surgery. So adenocarcinoma of the esophagus is not generally cured by radiotherapy alone because it's less sensitive. So to try to cure the cancer, most patients will have surgery. So in terms of the chemoradiotherapy that is used, there are two, this could be for squamous or adeno patients. There are two main regimens. The first, and probably the most common, is called the cross regimen. And that's two drugs given every week, carboplatin and paclitaxel. Because they're given every week, they're given at quite low doses. The next treatment, which is a more older treatment, is a platinum chemotherapy and a 5-FU. There are different flavors of that. And sometimes you can give chemotherapy before the chemoradiotherapy. Generally speaking, the radiotherapy is given for about 5 weeks. Depending on the chemotherapy that is used, the side effects could be hair loss, tiredness, increased risk of infection, sometimes an upset tummy. When we do the radiotherapy, there's mucositis, or burning of the esophagus, which can be quite painful and can stop patients eating. So I'll talk about nutrition in a minute, but that usually gets better after a period of a couple of weeks. When we talk about chemotherapy before and after surgery, the usual combination which is used now, and this was developed in Europe, is a combination of drugs called FLOT, which is 3 drugs: docetaxel, oxaliplatin, and 5-FU. This is given every 2 weeks, and the aim is to give 4 cycles before and after surgery. So the side effects of this are hair loss, the risks of mouth ulcers, the risk of infection, and it can cause numbness and tingling of the fingers and toes or nerve damage. The most important part of this chemotherapy is before surgery, not after surgery, because the surgery can be tough, about half of patients are not able to have treatment after surgery. When we treat gastroesophageal adenocarcinoma with chemotherapy and surgery, or chemoradiotherapy and surgery, about half of patients are cured. And in about half of patients, the cancer might return in future. So that's what we know the risk of the cancer returning when we look at the resection specimen under the microscope, and we can see some risk factors that might be associated with return. I'll touch on nutrition. I'm not a nutritionist, but we've got a great nutrition team in Cambridge. And so a lot of patients who have esophageal cancer are nutritionally compromised. They have lost weight and they need to gain strength to get through chemotherapy and surgery. So sometimes we put in a nasal, if they have difficulty swallowing, but they're able to take supplements, we'll recommend that they have supplements and we'll have them see our dietitian. In some patients, we might need to put down an NJ tube, which is a tube that goes right down through the nose here, in through the stomach and into the jejunum. So that's the small intestine. And leaving that there in the jejunum stays better than in the stomach. It's safer. And the patient can have a feed overnight, which will help them to regain their strength. And we need to monitor after surgery, especially patients who've had their stomach removed, micronutrients. Vitamin B12 needs to be replaced. We need to look at vitamin D and iron. And so good nutritional follow-up is really important in recovery for these patients. Now, I'll go on to treatment of advanced cancer. This is cancer that can't be cured by surgery. These is where our treatments, we've seen some exciting developments over the past number of years, or the past year, especially with immunotherapy. So when a patient has an advanced cancer that can't be cured by surgery, there are a few different biomarkers that we need to test. First, all patients need to have HER2 checked. 20% of patients have high levels of HER2, and they can have trastuzumab added to their chemotherapy, which is an antibody which helps it work more efficiently. All patients should also have microsatellite instability checked in their tumor or mismatch repair deficiency, because the small number of those who are MSI high have an excellent response to immunotherapy. So we should look for those patients. In probably the next year, we will have PD-L1 testing for patients with gastroesophageal adenocarcinoma, and we will have chemotherapy plus immunotherapy as an option, probably for patients who have PD-L1 protein at a reasonably high level in the tumor. So this is not licensed yet because the trial that developed this was only presented about 6 months ago. So it's very exciting to see this for patients, but we're not using it yet. The chemotherapy that we give at the moment, again, is a platinum and a 5-FU. So the platinum could be oxaliplatin, cisplatin, or carboplatin, and the 5-FU can be given as an infusion pump or capecitabine tablets. Now, all of those have different side effects, and some might suit some patients more than others. But as long as you're having a platinum and 5-FU, that's good treatment. There used to be a trend to give 3 chemotherapy drugs, and we're really trying to move away from that because we don't think now that it adds a benefit, but certainly does add side effects for patients. After first-line treatment, the options are a little bit more limited. And I would say also that only 40% of patients with adenocarcinoma receive second-line treatment because they may not be fit enough, because the disease can have an effect on their strength. Generally speaking, we can give another chemotherapy with a paclitaxel or irinotecan. Or there is an antibody called ramucirumab, which targets blood vessel formation. And that's been shown to be helpful with chemotherapy. But it's licensed in Europe, but it's not funded in the UK. So our patients in the UK just receive chemotherapy. And I put here at the bottom that nutrition and palliative care are very important throughout the patient journey. Because for my patients, I think that if they have palliative care at an early stage, it helps them to live longer and live better. I don't see this as mutually exclusive to chemotherapy, and I would really encourage them we really encourage us to have dual treatment between palliative care and the oncologists at all times. In the third-line setting, after 2 lines of treatment, we've had 2 exciting developments in recent years. So the first is a new tablet chemotherapy called trifluridine or Lonsurf, which is easier to say. And the second is immunotherapy with nivolumab. Now, again, nivolumab is not EMA licensed for this indication, but I know in some countries that patients are receiving it off label. So it's important to know. For squamous cancers, it's very much the same. We used to give chemotherapy with platinum 5-FU first line, but this year again, we've had the very exciting development of immunotherapy It's not yet licensed. I would hope to see it's licensed now in America, but I would hope to see a European license within the next maybe 6 months to a year. And we'll be able to offer these patients chemotherapy and immunotherapy. Let's just see whether they need the PD-L1 testing for this or not. In second line, for squamous patients, chemotherapy or nivolumab, immunotherapy. This is a new treatment last year, which got an EMA license. It improves survival compared to chemotherapy, but it's not available in every country. But certainly there is a license for this just granted in the past year. It's not yet funded in the UK. And in third line, we consider the same chemotherapy for squamous cancers. So just to say that for nutrition, it's very important also in advanced disease, but we can sometimes use a different approach. Stents are more important in patients with advanced disease. That is almost like a little tube, which is placed into the esophagus and then expands, holding the esophagus open. And they're very helpful in improving the ability to swallow. They do, however, sometimes have their own problems, so they can cause some pain and reflux. But they're helpful for patients who have difficulty swallowing. And radiotherapy is also an option, but that takes some time to work. Stents are most useful for esophageal tumors and not so much for tumors of the stomach, because the stomach is too big for them to expand. Just one word on the future. This is the last slide. So there's been a lot of work on the molecular biology of gastric cancer over the past 10 years, and there are new targets emerging, including FGFR2, Claudin, which is very important in diffuse gastric cancer. But drug development takes a long time, so it takes 10 years to develop a target and get the drug to market. Patients often ask me if they should have NGS or sequencing of their tumor, and I tell them that might be helpful for early phase clinical trials if they're willing to participate in those. But it's not standard practice currently because it's not informing our treatment. So that's the summary. So gastric and esophageal cancers share similarities, but also very key differences. For early cancers, we often use chemotherapy and radiotherapy to improve cure rates. In advanced cancers, the main treatment is chemotherapy, but some antibodies and immunotherapies might be used for suitable patients. And for me, the treatment of gastroesophageal cancer really needs to be holistic and to focus on nutrition and symptom control alongside active treatments like chemotherapy. And that's it. Thank you very much. Probably went a little over.